from Miami Beach, home of Neurosurgical TV. Today we have the pleasure of having Ashish Tandon, a neurosurgeon from India, who is going to start a live interactive neuroendoscopy channel. It's innovative, it's new. We just want some people really to participate with Ashish and to interact. That's the beauty of this platform. So let me introduce Ashish. Ashish, could you please get off your screen share so I could introduce you?
Yeah, sure.
Okay, okay, Ashish, it's all yours.
Okay. Very well. Good evening, friends. I'm extremely thankful to John and his team for starting a fresh channel, which is absolutely dedicated to neuroendoscopy, as well as minimally invasive brain and spine surgery. I'm Dr. Ashish Tandon. I'm a neurosurgeon here working in the central part of the country. The town is Jabalpur. To briefly introduce, I've been trained at All India Institute, and thereafter I've been a fellow at Toronto Western Hospital, Canada, and thereafter with Charlie Teo in Australia. My interest for MIS has been ongoing, and I'm really excited and very happy to learn and to see that over the last decade or so, MIS has really picked up, and neuroendoscopy has really picked up. So today I would want to share my thoughts on endoscopic lumbar spine surgery. And if John permits, I'll get on with my presentation. Is that okay?
Yes, it's fine.
Great. So what we really want is for the participants to sort of interact and be a part of this presentation. You can stop or question or interrupt me, and John will help us connect. Also, what I have done is I've got some models here to make it more interactive so that, I can show you exactly how things need to be done. Also, what we have tried to do is bring in some videos so that, you can learn. I've tried to get a lot of photographs, but please, you can stop me, interrupt me, and you can ask questions whenever you wish to. Basically, the idea is that we maximize the learning, and I would love all of you to get into endoscopic lumbar spine surgery. Okay. But these are my disclosures, and these are very important, especially for youngsters who have not entered into endoscopy. So my topic for today is transforaminal endoscopic surgery, but only 30% of my work, of the lumbar work, or I would say discectomy and foraminotomy work, is transforaminal. Rest 70% is interlaminar. That could be through the endoscope. It could be through the tubes. I'm a big fan of tubular approach. Or it could be other minimally invasive approaches for lumbar spine, like the Wilsey approach for pedicle screws, and then missed TLIF, and so on and so forth. Now, the other disclosure is that I routinely perform minimally invasive spine surgery, and I, in fact, started with endoscopic cranial surgery. So, right now I'm into two-dimensional endoscopic surgery. So that has helped with the learning curve. So every endoscopy that you are involved, that 2D feel and the feel of the anatomy and what you're visualizing sort of helps you with the learning curve. I would confess that I have had my fair share of failures and complications. So I do not want to sort of make you feel that this is absolutely a surgery where you do not have failures or complications. Failures are easier to manage because you can counsel the patient. Complications become a little more difficult to manage and to digest as well. But when you are going through the learning process, and even at a very high stage, you would still have failures and complications. So there is a steep learning curve, and I myself have gone through this steep learning curve, but you'll have to be to it, you have to keep on doing it to get a hang of it, to get a feel of it. So how many of you do transforaminal blocks? So how many participants do we have right now?
Right now, there are 27.
Oh, okay. So anybody want to take this question? How do I know anybody is answering? Okay.
Well, they can answer directly. They have audio.
Yeah. Okay. So how many of the participants here do you undertake transforaminal blocks? Do you do transforaminal blocks regularly? Anybody can answer it. Nidhi is there. Nidhi, do you do transforaminal blocks?
Yet. No, sir, I haven't done yet.
Okay. And what about Ninad?
No, sir, no. In my institute, no.
No. Okay, fine. Then there are others from various different countries. Anybody who wants to take up this question? Siraj is here. Vinayak. Okay. So if I'm not wrong, then there is a good number of neurosurgeons who are not doing the transforaminal blocks. So, okay, so please start doing transforaminal blocks. Unless you do not put the needle there, you will not, sort of climb the stair. So start doing transforaminal blocks. I must tell you, it is very simple, straightforward, nothing magical about it. There is nothing like a learning curve for it. You can do it right away. And because now I know that a lot of participants have not done, so I will sort of change a bit of the direction and help you with the transforaminal blocks as well. Okay, so if you have not done transforaminal blocks, then I'm pretty sure that you haven't undertaken percutaneous endoscopic lumbar discectomy as well. So the first step is doing a needle insertion in all your cases. So in OPDs, if the patient agrees, just put in steroid and local anesthesia and give blocks. Okay. Now I think my position has become really more and more difficult, because if you have not done blocks, then making you understand the anatomy would be still more difficult. But anyway, what I'll do is I'll start with teaching you about the foramen. Okay, because it is transforaminal surgery. Okay, you get it? So for transforaminal surgery, you are going to enter through the foramen. So this is the foramen. So L45, L34, L23, etc., etc. Now, if we want to learn about the foramen, okay, the other thing that I would be doing here is, John, how can I have my photograph here while I'm talking? Can I get my?
What do you want to do?
I want my video running when there's just one person. Can that be done? Like right now, I can see you, but I can't see myself. So I don't know, whether
What, you want to screen share the video?
Sir, when you speak, you are being seen.
Yeah, go ahead. Tell them.
I can't see myself.
We can see you, sir. When you speak, we can see you.
Okay, fine. Fine. Okay, so now also throughout my presentation, what I have tried to do is I have tried to rotate the image in such a fashion that you will see what you would be seeing there in the operation theater. So, like for example, here what I've done is we see the X-ray like this, you know, standing X-ray. But when you are doing the surgery or when you're doing the block, it's in prone position. Okay. So this is the target area. Please, everybody note, this is the target area. So L45, L34, this is where the whole art is all about. This is the focus area. Now let's see about the foramen. Now I'll keep on talking about the foramen for next 5 or 10 minutes. So foramen, as you can see, is an oval structure. And the height of the foramen is about 1.5 to 2.5 centimeters. Fine. And there is progressive widening of the foramen. So you see the foramen is a little narrow here, but as you come down, it becomes more and more wide. Okay. Now, this is the MRI. We are used to watching the sagittal, mid-sagittal, or just parasagittal sections. We do not focus too much on the foramen. But if you want to sort of take up transforaminal surgery, or for that matter, even endoscopic interlaminar surgery, you should know how to see or read the MRI on through the foramens. Okay, so this is the foramen here, and here is the superior articular process. This is the superior edge of the inferior vertebra, the end plate. This is the nerve root. Okay, so this is the nerve root passing through the upper half of the foramen. Okay. Now here, what happens? See, from the foramen, the nerve root is coming out. It is coming down, and it is moving anteriorly. This is very important. So please start picturing. So again, I'll bring this. Can you all see this model that I've got here?
Yes, sir.
Yes, sir.
Okay, so now you see what is happening to the root. The root here is coming down and it is going anterior. It is moving anterior. Okay, so that is what is going to happen here. So this is how you will see the foramen and the structures when you're doing a transforaminal approach. So the root, this is the exiting root. So please understand when I understand the anatomy, okay? So this is the exiting root. So for L45 disc, L4 is the exiting root and L5 is the traversing root. You see the root here going down and then it will be coming out from here. Okay, so the root is coming out of the foramen from the upper part, moving down, but moving anterior. Okay, when you are giving a block, when you are putting in a needle in the foramen, or when you're doing a discectomy, please remember you are coming posteriorly. You're coming from the posterior part. So all surgery you're doing from here. Okay, you get me? So the chance of injuring this exiting root is low. Okay, next. So for me, L34 and L45 are anatomically favorable disc herniations for a lumbar transforaminal discectomy. L5S1, because of the iliac crest, which is usually very high, I do not go in for a transforaminal surgery. I rather approach it through interlaminar approach. Also, the interlaminar window is really big in L5S1. So I take an advantage of that, and then I use interlaminar approach there. So from L12 to L45, a disc which is favorable for me, where according to me, I don't find a contraindication, I would prefer a transforaminal approach. Okay, now this is very important. Now, these are the ligaments around the foramen. So to explain you this photograph, this is the foramen here, okay? This is the facet joint. This is the disc here, pedicle, the superior pedicle, the inferior pedicle, okay? So around the nerve roots, you have the intraforaminal ligaments, okay? These are called as transforaminal ligaments. So there's a superior transforaminal and there is a mid-transforaminal ligament, okay? Now, the ligament, the exiting root, again, this is very important for all of you to understand that the exiting root is a fixed structure. It is not a mobile structure as we see in the traversing root. The traversing root is relatively free. There are no ligaments holding it, whereas the exiting root is. So it is a little more firm in its position, okay? And it is because of these ligaments. And this is precisely the reason why you have the SLRT positive. Because, you know, the ligament, whichever root is being stretched, it can't move a lot. So that is why the SLRT comes positive. Anyway, now, again, to make you understand the bony anatomy, I'll go to this slide again. So you see the foramen superiorly, the foramen is bounded by this pedicle of the upper vertebra. Then you have the facet, mainly in the lower part of the foramina where you would be doing all the job. You have the superior articular process. Then you have the lower pedicle, and then you have the disc. So again, in this fashion, when you see, when you're going inside, also for this presentation, specifically what I have done is, I would be only dedicating the whole of anatomy for the left side. So if you're going from the left side, I don't want you to get confused between left and right, okay? So for this presentation, anything on the left is cranial, anything on the right is caudal throughout the presentation. So let's see, here you have the superior articular process. So when you see through the endoscope, the superior part would be the superior articular process. The right side would be the pedicle. The left side would be fat and the nerve root, okay? And inferiorly, you will have the posterior longitudinal ligament and the disc, okay? So friends, I'll just take a break for a few seconds here, a minute, and have the participants able to digest what I'm saying. If there are questions, please ask me. If you have questions up till now, please feel free to ask. I think you all are unmuted. You can ask. Is it clear up till now? Can somebody give me a feedback?
Yes, sir. Clear.
Okay. Everybody is fine?
Yes, sir.
Jitin,
Yes, sir.
everybody. Okay, fine. Okay. So again, see, so why I went to the previous CT scan is, now you will understand that the facet is here. This is the superior pedicle. This is the inferior pedicle. This is the disc here. And here on the upper side, when you are seeing the foramen like this, Okay, if I rotate it, then obviously the left would be the nerve root. Okay. Now there is a vascular supply also, and this triangle here is the Kambin's triangle. There is an arterial supply, there is a lumbar branch, lumbar artery, and there is a vessel supplying above the nerve, exiting nerve root, and there is an artery going just beneath that as well. So it makes sense to have, see this area, look at this area. This area does not carry a lot of neuro or vascular structures. So it makes sense to enter the needle from here. Okay, fine. Now I will be talking about the Kambin's triangle. Now, Professor Kambin was the gentleman who taught us, who described this safe triangle or safe zone to enter. But what I would want you to understand is that this Kambin's triangle is a three-dimensional triangular area. So when we say triangle, we mean 2D, right? But here there is it's a triangular area which is three-dimensional. So that means as you go inside, so on top, like I'll show it to you here. See, if you see here, this is the exiting root. This is the articular facet here. And when you're going in, so up to the theca or the traversing root, that whole is a triangular area. That is the safe area. Okay. Now, this triangular area, the base is formed by the superior end plate of the inferior vertebra. Fine. And then you have the superior articular process. So the under surface of the superior articular process, and the hypotenuse is formed by the exiting nerve root. Okay.
Sir, where will be the that artery in this diagram?
Okay, so the artery would be somewhere here. Okay, somewhere here.
Okay, sir.
Okay, like did you see here? Yeah. So this is not a true lateral image. Okay. Now when we flip it, like, sorry. Yeah. So in this, we need to stay here. Okay.
Okay.
Right. So now again the same thing, the Kambin's triangle here. This is the Kambin's triangle formed by the exiting root, formed by the traversing root medially and laterally by the superior articular process. So here we have removed the superior articular process to show you the traversing nerve root. Okay. So this is the hypotenuse. Traversing root is the perpendicular part, and the base is by the end plate. Okay, so this zone is a safe zone. Okay, now if we look at the cadaver here, again the exiting nerve root would be coming like this. As I've already told you, it goes, the exiting nerve root goes down and anterior, and the whole of our procedure is from posterior. And please try to develop a 3D image of what I'm trying to teach you. Okay, so when you are, now I've again rotated, when you will put in your scope, to the left would be the exiting nerve root. We don't want to touch it, we don't want to damage it. Superiorly would be the superior articular process. So practically the inferior inferior margin of the superior articular process. That would be toward the lateral side of the foramen. As you go medially, you will have the traversing nerve root. And the base is formed by the pedicle and the end plate. Okay. So also you should be aware of this anatomy. The Kambin's triangle gets wider till L4-5. That we have already seen, because the foramen becomes wider. So the Kambin's triangle also becomes wider. However, it is a bit narrower at L5-S1. But I would suggest that let's forget L5-S1 for transforaminal surgery. Now, there is an important aspect of the exiting nerve root as well. So for exiting nerve root, you have the dorsal root ganglia here. Okay. Now the ganglia keeps on moving inside as we come down. Okay. From L12 to L5S1, the ganglia moves a bit inside. This area, okay, what is this area called? Can anybody tell me which is this area? Anybody? Which is this area called? Routine.
Axilla.
Axilla. So the ganglia is moving more towards the traversing root and to the spinal canal as we are going in. Okay, great. Fine. So this will be the picture for you when you are looking through the endoscope. So you'll have the disc, you'll have the traversing root. On the left would be the exiting root. Left inner when you're approaching from the left side. Okay. Now this is again important. See, this is a cadaveric picture here. The exiting root is coming beneath the pedicle. There is a medial aspect and there is a lateral aspect, and this whole is the foramen. Okay. So you see, this is the safe area. And as I've already told you that the root is moving anterior, whereas you are coming posterior. So you have this big area to cover, and not just this big area. You can even go up to here and you can go up to here. Okay. And that is, this picture will tell you the extent of disc herniations which you can attempt through a transforaminal approach. Okay. Okay, this has gone reverse. Fine. Now let's see, you have already put in the endoscope and what you will see. So I've already told you that inferiorly you will have the disc. Then you will have the, so disc and annulus, posterior longitudinal ligament, you may find the disc fragment, dura, and ligamentum flavum on top, a little bit of fat and exiting nerve root to the left. On to the right, you will have the pedicle. Fine? Okay. Now, very important, this is a lateral disc. In case of a central disc, there will be dural sac here because the disc has herniated centrally. Okay, so the dura would be first, and then when you go in, you will have the disc fragment. So depending on your MRI study, you will know where this disc fragment needs to be searched for. Okay, now these are my list of cases that I will do through the transforaminal. So only 30% of the disc herniations or lateral recess I would be selecting for a transforaminal approach. So I would go in for an acute prolapse. Previously, I had avoided central disc, but not now. So central disc herniations, paracentral, foraminal, and extraforaminal. I can attempt all. Extruded discs, not a problem. Far lateral disc herniation, we have already discussed, not a problem. Sequestrated disc to a certain extent. To what extent, I'll just show you through a X-ray. I also undertake disc infection debridement. So in our country, we have a lot of pot spine. If the patient does not have compression, I would go in, enter that area through a transforaminal approach, wash, take a good biopsy, send it for culture, send it for gene expert, etc., etc. And then a few of cases of foraminal stenosis, I would manage through a transforaminal. Okay. Now, this is the extent of herniation for me. If I will find a sequestrated or a further cranially migrated disc on MRI, then I will not go for transforaminal. Or if there is a caudal migration beneath this line. So for me, just beneath the upper pedicle. So if the herniation has crossed this part, then I would not attempt that through a transforaminal approach. Similarly, if there is caudal herniation, caudal migration, which has crossed the middle part of the lower pedicle, then again, I would not attempt for a transforaminal surgery. Other contraindications, I would not attempt a calcified disc, severely migrated or a sequestered disc herniation beyond the limits, central canal stenosis is out, and if there is associated instability. Though I am in the initial part of my learning curve, or I would say the very basic of fixation or stabilization through a lateral approach. Okay. So I'll again take a break. If you have any questions regarding specific slide or anything that you've not understood, please feel free to question. I can go back onto my slides and explain. So
Sir, I could not listen last slide of contraindication because of network issue. Could you
okay,
please,
so can you see now?
yes, sir.
Okay, so calcified disc, get a CT scan initially in your initial practice, always if you are attempting transforaminal. And also I must tell you, it is very cheap. You know through an MRI that you want to operate on L4-5. So what I will ask my radiologist or a CT scan center is, I just want a single image through L4-5. They would charge about 500 to 1000 rupees. I don't want a film. I just want it WhatsApp to me. Okay. So you don't need to spend a lot of money on the CT. Then migrated sequestrated disc herniation. So sequestration above this or below this, I would not attempt. Then central canal stenosis is out of question, and if there is instability. Okay, Nidhi?
Yes, sir. Thank you, sir.
Anybody else, if there are any questions till now? Anybody? No? So have I made clear? Are things clear till now?
Yes, sir.
Okay. So what we have done, this is the first half of the lecture. We have studied about the foramen, about the indications for transforaminal surgery, about the anatomy of the foramen. That's very, very important to understand. The contents of the foramen. And then I've tried to help you to sort of develop a 3D anatomy, because that is very, very important. Okay. So let's move on. Now, when you're starting, please discuss with your anesthetist. Previously, I used to operate under local and sedation, but now I have gone to GA. So all my transforaminals I do under GA. You have to educate your C-arm technician about where to shoot. So because what happens is we are at the lateral part, so he feels that he needs to shoot the entry of the needle, or where the endoscope is. You have to first and foremost educate him that you need to focus on the middle of the spine. So every time he will try to move towards you, you have to tell that you want a mid X-ray. Second is a patient positioning. I'll talk about that as well. Okay. Now pre-op, appropriate counseling of the patient. You tell them that we are attempting transforaminal. There is a possibility of complications or residual, in which case we may convert, or we may take him up at a second stage. I start antihypertensives, anti-anxiety if required. CT scan, as I've already told you, look here, there's a fragment here. If you go transforaminal, you're not going to achieve anything. Also X-ray, this I used to do before X-ray to review the iliac crest. But now because I have already...
Presentation is freeze, sir.
Hello?
Only your voice is being heard, your presentation is freezed.
Okay. Now, is it moving? Is it moving?
Yes,
Yes, sir.
yes.
Yes, sir, moving.
Okay. So you need to see the iliac crest, but because now I've stopped doing L5S1 through transforaminal, so I'm not bothered. 95% of cases, L4-5 would be at either above the iliac crest or at the level of the iliac crest, or even a little bit lower, and you can easily accommodate your trocar and your sheath, etc., etc. Now, see, for me personally, I have shifted from posterolateral approach altogether. I do not undertake posterolateral approach anymore. So what is a posterolateral approach? So from the midline, there was a calculation of the length and angle. I've stopped doing all that. I have shifted myself from posterolateral to lateral approach. Okay. So what I have started doing is, and there is a big German group whom I personally follow. They have also shifted. They've always been doing lateral approach, and for me, last about 1.5 to 2 years, I have shifted from posterolateral to lateral, and I feel much more comfortable. My radiation exposure has reduced. I do not need to do multiple C-arms. And it is, for me, it's all lateral approach. So what I'm trying to show you this is, in this photograph is, posterolateral is this approach. You're coming at 45 degrees, entering into the foramen, and then you're entering into the disc. Whereas for me, my entry point at L3-4 and L4-5 is here. Is here in the sense, there's a line which I'll see on the X-ray, which is touching the facet and lamina. And when I come out as lateral as possible, that is where my needle enters. So I am very sure that I'm not going to injure any abdominal contents or kidney, or I will not create any retroperitoneal hematoma. Okay. For L1-2 and L2-3, so for higher level discs, my entry would be at this level. So I'll be coming much more higher up, okay, towards the back. Okay. Why? Because there are more, there's less of muscle and more of abdominal contents at a higher level. So I would go a little higher. Okay. Now look here. Now for lateral approach, I would not go from here. Rather, I'll go almost from a line which is joined here and it is touching the skin. Okay. So I'll explain it to you further. So when you are doing the procedure, from here, you mark this point on lateral X-ray, bring it out, and the point there would be sort of the entry. Okay. Now, why I have shifted to lateral approach and why not posterolateral? So for me, lateral approach, because I want to see neural structures as much as possible when I'm doing the procedure. I want to see that my traversing route is free, my ventral part of the theca is free, and I would not be very happy not seeing the neural structures. So that's one. And because I'm entering into the spinal canal, I'm not entering into the disc. I'm entering into the spinal canal through the foramen. So the participants need to understand that when we are going posteriorly, we create a window here. Okay. Either we cut the interlaminar space, or we do a laminotomy, whatever, and then we go in. Here, God has already created a foramen here for us. So I'm using that window, but I want to see the neural structure. So I enter into the spinal canal through the foramen. Now, the disc is removed under direct visualization. I can see the disc fragments and I would remove. And finally, as I've said, that all neural structures are visualized. Now, the lateral approach is also possible when there is a narrow disc space. So if you have a disc herniation and there is hardly any space between the two end plates, still you can do this approach because you're not entering into the disc space. You are above the annulus. And you can, this is a very important point, that you can manage whether it is a canalicular disc, foraminal disc, extraforaminal disc through the same entry. I will not change my entry point. So, like for posterolateral, you must be aware that for a posterolateral, they take about 8 to 10 centimeters, 12 centimeters, and then they go for a paracentral disc herniation. For extraforaminal disc herniation, they'll be very near and they'll be going like this. For a lateral approach, as I do, that is the only way I enter, period. I don't need to see whether my entry points are fixed. Now, for me, pre-surgically, the patient is under GA. I feel if the patient is more comfortable, he's not moving, there is no stress, I can easily do my surgeries. I use prone position with flexion at hips, very similar to interlaminar. I want to remove the lordosis of the lumbar spine. I just make it flat and then I undertake the skin markings. Now, I would explain it to you how I go about the skin markings. So, the first thing that I do is I mark the midline and I have my K wire with an AP view, which I mark up to the center. So the center of the affected disc herniation, like in this case, it's L45. I would mark the center here and then I would draw a line. I'll draw a line and that line will go down up to the lateral part as well. Okay. Then after that, I would shift on the lateral X-ray. And on the lateral X-ray, if the disc herniation is L34 or L45, then I would mark the laminofacet junction. Higher up, I would mark the tip of the spinous process, L12 or L23. This I have already discussed. So look here. First, I'll see on AP, I'll see and I'll mark that level till the lateral part. And thereafter, I will take a lateral X-ray, and on a lateral X-ray, this is my marking. If it is L45 or L34 disc herniation, my lateral marking is here. So my K wire would be kept here. Okay. So if I find this on a lateral X-ray showing that it is on the vertebral body, then I'll keep on going up till I find the laminofacetal junction here. In higher up, I would just mark the lateral onto the tip of the spinous process. Okay, is that clear?
Yes, sir.
Friends, is
Yes,
it
sir.
clear?
Yes, sir.
Okay, so what I am trying to teach you is a lateral transforaminal surgery and not posterolateral, and how I mark. So that's very important. I hope you all are digesting all this.
Yes, sir.
Is it clear till now?
Yes, sir. Yes, sir. Very well.
Okay. So on the lateral X-ray, you are also able to confirm the level, L45, L34. You will not make a mistake for the level as well. Okay. Now, I'll now go on to the steps as I perform. So I would insert the needle first on a AP view. Now, when you are inserting the needle on the AP view, it is important to understand that there should be no parallax. Now, I would ask my first question here. What do I mean that I remove parallax on an AP X-ray. So can anybody take up this question? In this X-ray, can you tell me at which level I have removed the parallax and at which level you can see that there is a parallax? Anybody wants to take up this question? Enrique Corizza. Enrique, are you with us?
Well, we will get better with the interaction.
Okay, so I'll Gautam. Is Gautam here? Unmute yourself, Gautam. Talk to me. Gautam, are you here?
Yeah, we're gonna go through a learning curve with
Feel
this
free to
technology.
talk. Okay, then I'll go to maybe Ninad. Ninad, are you here? Can you hear?
Yes, sir. Yes, sir.
Okay. So Ninad, I'll make it more simpler. By parallax, what I mean is that the end plates should be at the same level. You cannot have the end plates on AP as two different lines. So tell me, is there a parallax at L4 vertebra here? Yes or no?
L4.
So this is the L4 vertebra, right?
Yes, sir. Yes, sir.
So is there a parallax here?
Means end plate is parallel. You are asking end plate is parallel to your needle, like?
No, not parallel to my needle. Parallel view. You are absolutely end on with the end plate. So everybody, please try and understand. I'll give you the answer, Ninad. See, here you see a single line. Here you see a single line. Just try to focus here. Here you see two lines. You understand? This is the end plate which is seen because of the angulation of the vertebra. This you don't want. Here, if you see L5 vertebra here, you see this is the anterior end plate, this is the posterior end plate. You see it like an oval structure? Ninad?
Yes.
Yes, sir. Yes, sir.
Yes.
Anna? So
Yes, sir.
you saw this, right? So
Yes, sir.
this is not an end-on view. This is with a parallax. These
Okay,
are
sir.
not parallel. Here I have removed. And how do you do that? When you hold the C-arm when it is in AP and you tilt it. You understand? So
Yes.
till you get absolute no parallax.
Okay, sir.
Okay. So till that point, you will go in for, you get that view for that particular disk space, and then you do your marking. So that is very important to understand. Second important thing is, this is the medial pedicle line. MPL means the medial pedicle line. I marked this in red. Never cross the needle beyond the medial pedicle line. Okay. Why? Because the theca is from here to here, isn't it?
Yes, sir.
The theca and the cord are between the two pedicles, isn't it? The lumbar roots are going in between the two pedicles. There is no neural structure from here to here at the discal level. At the discal level, there are no neural structures up to this point. Now, suppose if I insert this further, it can go and injure the dura and you can have a leak. So this needle should never cross the medial pedicle line. Okay.
Oh,
also,
okay. Excuse me, Ashish, we have a couple of questions here, if you don't mind.
Sure.
Well,
Yeah.
Pankaj Chandran asks, do you mean you could attempt a centrally herniated disc, but not central canal stenosis due to same?
Yes, Pankaj, you are absolutely correct. I can very easily attempt a centrally herniated disc, but I cannot manage a central canal stenosis, not due to the same. Central canal stenosis because of lumbar canal stenosis, which I mean is secondary to ligamentum flavum hypertrophy and buckling. So I won't be able to with this procedure, you can generally deal things within the foramen and ventral to the dura. It is very, very difficult to go dorsal to the dura. I hope I have answered this question. So I can deal with central discs, herniations, but I cannot deal with a central canal stenosis secondary to ligamentum flavum hypertrophy, or because of the facetal hypertrophy and arthropathy as well.
Okay, we have another question. Do you use intraoperative monitoring?
I'm sorry?
Do you use intraoperative monitoring?
Okay, so I do not use intraoperative monitoring, but see, for those who are using this procedure or doing this procedure under local anesthesia and sedation, obviously, the minute you touch the root, the patient is going to tell you, okay, that he has pain. However, I am doing under GS. So what I ask my assistant to keep a hand on the thigh leg when I am docking the needle, when I am inserting the dilator, when I'm inserting the sheath. Once the sheath is inserted, everything is in front of me. I can see it. So at that point of time, my assistant removes the hands from the thigh and leg. That is a natural feedback that he or she gives. And the minute I touch the needle, my assistant tells me that the muscle is moving. So I have to redirect myself. So that is a very good way of monitoring intraoperatively. Okay, no parallax. Pankaj again asked. I think I've answered this about parallax. Yes, it is clear. Yeah. Okay. So you can ask more questions on this, or you can interrupt. Okay, so where was I? Okay, so insert the needle always on AP view. Okay, so keep on in the initial part, keep on shooting 1, 2, 3 X-rays till you have reached here. Never cross the medial pedicular line, and at that point of time, note how much is the length of the needle that has gone in. So there are markings on these needles. This needle, the markings, you need to see near the skin entry point what the marking is. So you approximately know how much the sheath has to go, how much the dilator has to go, so that you don't need to shoot it again and again. You need to minimize the radiation. Okay, now once you have seen the AP, you brought it here, now you want to confirm that on lateral. So this is the position on lateral X-ray. You just want to touch the annulus. The posterior annulus is here and the needle has to be docked here. Now look at the position of the needle in both of these X-rays. Look here, the foramen is from here to here. I am in the lower half or lower third of the foramen in the AP view. And in the lateral view, see, this is the foramen here, from here to here. Again, I am at the lower 1/3 of the foramen. Now, if I draw the Kambin's triangle, the Kambin's triangle is the traversing root, which is somewhere here. The exiting root is coming, the exiting root is coming anteriorly somewhere here, I'm sorry. Then you have the end plate and you have the superior articular process here. Is it clear? I'll tell this once again. So exiting root is coming out from here, going down and anterior. That is the hypotenuse of the Kambin's triangle. You have the end plate of the superior vertebra inferior vertebra and the superior articular process. So this is the Kambin triangle, and we have entered bang on in the safe zone. So lower half and tip is posterior to the annulus. Now, so first the needle goes in. Also before that, now that I'm used to this procedure, I would make a 8 millimeter incision first and then get the needle in. And once the needle, I have confirmed the position of the needle, then I push in the K wire. Once the K wire has been pushed in, I get the needle out. K wire is blunt at the end, so it is not going to injure. Also, because of the feel, I know that whether I am moving inside the disc or not. Then over the K wire, I would push the dilator till again the medial pedicular line. Okay. Once I've done this, so this is the dilator, as you can see here. I'm pushing in the dilator, and over the dilator, I push my sheath. Now I've brought this. So this is the dilator. Okay. So if you can observe, okay, can you see the tip of the sheath? Is it clear? Can you see it?
Yes, sir.
So there are two openings. One is this, the other is this. Okay. Now, why two openings? One, in case if I want to adjust, if I'm not very happy with the position of the dilator, I can just remove the dilator without removing the K wire. I can use this opening, which is a little to the side. So I can move a bit. The second is I can inject through this opening local anesthesia, as I am going in. You just push in a fine. Also, from the other end, you see there are two holes. Okay. So through the center one, the needle is coming out. Through the other one, you can inject local. So while you are pushing it in, especially in surgeries where you're doing it under local and sedation, you need to keep on injecting a lot of local so that the patient does not have pain. Also, when the sheath and the dilator is going inside the annulus or near the annulus, it is very painful. So you need to inject. Okay. Now, this is the sheath. This is the sheath. Okay. It has markings on it. Markings, and it is a beveled sheath. Okay. It's a beveled sheath. So when so my dilator is in, and when I am pushing the sheath inside, the beveled edge is towards the exiting nerve root, so that I don't hit the exiting nerve root. So I'm going like this. If it is if the exiting root is like this, I'm going like this, and thereafter, once I'm inside, I will rotate another 15-20 minutes. So thereafter, I will rotate. Okay, and then the position of the sheath would be like this. Can you appreciate? So when I am going inside, I'm going like this. So something like this. And here is the exiting, so that I don't hit. Okay, so again, I would confirm that this is near the medial pedicle line. And then I would rotate the bevel, so that what you see is in front and above. And why is that? I'll try to explain that as well. Okay. On lateral also, I would want to confirm my position of the sheath. Okay. So it is near the posterior annulus, and this is a 8 millimeter sheath. So if it is here, you're absolutely sure that it is not only visualizing the annulus, but also the PLL and the dural structures. Okay. So again, I'll take a break here, and I'll open this for any questions or discussion till this point.
Sir, can you show that CM picture of K wire just before putting dilator? Yes, sir. Yes, sir. So this K wire is going till center.
Yeah. So see, the reason why we didn't push the needle is sharp. It can injure the dura. For this to injure the dura is very limited, and also I have already confirmed that I am touching the annulus here.
Okay.
Okay.
Slide it over the annulus, like.
Yes. So I am either sliding it over the annulus or I am going inside the annulus.
Okay. Yes.
And you will get a feel of it. The
Okay.
reason why you need, basically what happens is we try to keep it here, but little bit of movement and that K wire can come out. So you will have to sort of do the procedure again.
Yes, sir. Okay.
Okay. Yeah. Any more questions?
Hello, sir.
Yeah.
Sir, I want to know, like, you're inserting the needle in the AP view. Like,
Yes.
how sure are you that really when you're going towards the midline from the lateral aspect?
No, please ask the
Like,
question
we are
again.
not damaging the abdominal contents.
Oh, okay. Right. Okay. So this is a very important question, and what I'll do is, okay, how do I explain this? Right. So suppose I know that this is my point, or I am showing this, but in this case, I'm pretty sure it must have been somewhere here. So suppose I know that this is the laminofacetal junction at L34, L45. Okay. So beyond this, there would be abdominal structures. Okay. So let's see this photograph. So if I am entering from here, everything beneath this, everything above this would be muscle. Okay. And everything to after a particular angle, it would be abdominal content. So in my practice, what I do is I try to go and hit the bony structure first. So my needle, and the best area to hit the needle is so the best area to hit the needle is somewhere, say for L45, it is somewhere here. So you are hitting the facet. The abdominal contents, here you have the psoas muscle. So the abdominal contents are all beyond this. Also in prone position, the abdominal contents are further falling down. So if I am hitting this structure here, bony structure, under no circumstances can I injure any abdominal structure. That's very sure. So if you are in your initial cases, try to take the needle, when you're inserting the needle, try to insert it straight. Hit a bony structure and then bring the needle out a bit and then let it slide in. Okay, that is number one. Number two, for this I am showing you the sheath. Okay, suppose this is the needle. Suppose this is the needle. The needle moves away from the bevel. This is a golden rule that you should all remember. The needle moves away from the bevel. So what do I mean by this? So can you see this? So the bevel, the opening is here. This is the sharp portion. Now, when I am pushing the needle like this, the needle will not go straight. The needle will go like this, away from the bevel. You understand? Who was asking this question?
Vinayak.
Yeah, Vinayak. So your needle will go like this. Fine. So if you are not comfortable, you just rotate the bevel of the needle down. You get me? So when you are inserting, your needle is going up. It will automatically flow up because these structures here push the needle to go up. It doesn't go straight. Okay. So that is point number one, how to use the bevel of the needle. Point number two, when you know that anything below this level, suppose this is the mark, or suppose I marked, suppose this is the mark. So if you see, my angle is a very, very minimal. In posterolateral, what happens is there is a 45-degree angle. For me here, it is almost bang straight. Okay, Vinayak, is that clear?
Okay. Yes, it's clear.
Okay, fine. Any more questions? Any more questions?
Sir, continuing the same question, like, so once you reach on AP and you know that you have hit some bony landmark like superior articular process which you are aiming to hit, subsequent to that, do we have to change the angle looking at the lateral view?
Yes. In the initial period of your practice of transforaminal blocks and transforaminal discectomies, the same trajectory you will use for the block. Okay. So for example, your needle is here, right? For a block, your needle will be here. Okay.
Yes.
So in your initial practice sessions or block sessions, you will know when your needle is hitting the disc, when it is hitting the bone, and when it is entering into the foramen. So, but initially you may require more X-ray shots to confirm. Okay. So your needle should be somewhere here. You get me? When you're giving a block.
Yes, sir.
It should not cross this line. It should not cross this line. You get
Yes,
me?
sir. Yes, sir.
Let me draw. Okay. So under no circumstances, can you all see this, what I'm drawing?
Yes, sir.
Okay.
We can see.
Yeah. So under no circumstances, your needle should cross this line. Okay. Why? Because your exiting root is coming here. Then a little more anteriorly, you will have vascular structures, the sympathetic ganglia, so on and so forth. So you don't want to pass beyond this line. So try and hit these posterior structures. We are all used to these posterior structures. Left, right, and center, we expose every day, you know. Okay, any more query up till now? Gautam is here. Marcelo, can you hear me? Dr. Polo, Siraj, Rajesh. Okay, fine. If no questions, no problem, but feel free.
Someone had something to say there. Go ahead, whoever had a question. If not, okay, it's over to you.
Okay, so there's one question from Lion Castillo, and he's asking me at what angle was the needle inserted. So for me, I'm not going to give you any angles. Forget about angles, forget about distances, forget about lines. You believe on the X-ray. Okay. And once you know that, this is the entry point, just go bang straight or a little bit down, because you know that you have to go a little bit down. But in your initial practice sessions, just go straight, hit the bone, hit something. Suppose if you're not hitting the bone, that means there is a possibility that you have gone beyond the spinous process, above the spinous process. Okay, that you can confirm through a lateral X-ray. But just go straight, hit the bone, pull out, angle a bit, and go in. Fine? Castillo, is it clear? Thank you. Fine. Okay, so we move ahead now. Now, after this point, I get my scope in. Now, it is very important for you to know the scope. Okay, you need to know the scope. Now, the scope in transforaminal discectomy is a 25-degree scope. Okay, so when you are looking, you're looking a little up, 25-degree up. Okay, so for all those youngsters who are getting into endoscopy, let me tell you that as a neurosurgeon, 20 to 30-degree scope is the scope for action. 0-degree scope is to visualize, to understand where things are. But the minute you want to do a procedure, you need a 25-degree scope. Whether it is brain, so when I want to get into the third ventricle, I hope most of them are neurosurgeons here. When I'm entering into the third ventricle, I use 0-degree scope, or many times I use 25-degree scope and go for endoscopic third ventriculostomy. For a colloid cyst, I'll go in with a 0-degree scope, see everything, know exactly where the anatomy is. Then I'll insert a 25-degree scope to excise my colloid cyst, because you can handle the instruments better. The same is true for the spine as well. So transforaminal or interlaminar. Now, there are a lot of youngsters who may require to purchase a lot of equipment. Just go for one scope, one system. With that, you can do all transforaminals, you can do all interlaminars. And I must not say this, but I use these scopes many times to evacuate the hematoma also. These are so versatile, and you have all the equipment. So you can just go and use it in brain as well, or to see structure. This is an 18-centimeter scope, and it has a 25-degree visualizing angle. Through this scope, you have the light source. As you can see here, the light source is connected. Through one port, you have the irrigation. Now, a few words for irrigation. There is a point for inlet and outlet. Also, if you see the sheath here, there is another outlet on the sheath as well. So the scope is going to go inside this. Okay. And this is for irrigation to come out, but it can also come out through the scope. The scope has two, one entry for irrigation in and the other for out. The irrigation, I generally avoid using pressure sources till now. I may use it in the future, but I just use gravity to let the fluid in. So this surgery, whether it is transforaminal or interlaminar pure endoscopic, the surgery is being done under irrigation. So there is a lot of irrigant fluid. I use normal saline, and the pressure is decided by the height. Also, I use two types of irrigation bottles. One is a 3-liter that I use, that is just guided by gravity. The other I use is a 1-liter bottle, on which my pressure pump is attached around the bottle. So when there is profuse bleeding and I can't see anything, I want a lot of fluid, my assistant, the nurse, anesthesia nurse, just puts in more pressure. There is more irrigation through the pressure, and I can pinpoint where the bleeding is and I can do RF. Okay. So this is about the scope. Also, the advantage of a transforaminal endoscopic procedure is that this sheath is snugly fit inside the foramen. So you don't need to do anything with this sheath, or not a lot. As you increase your experience with the procedure, you would like to move in, out, so on and so forth. But this is snug. So the only thing you are holding is the scope and instrument, and you can move the scope in, out, you can rotate it. Okay. So it is much easier than doing a pure endoscopic or a full endoscopic interlaminar, where you are holding the sheath as well. So imagine with one hand you're holding the sheath and the thumb is moving the scope, and with the other hand the instrument. Sorry. So this is about the scope. Any questions for the scope? Okay, there are some 4 questions here. Let me answer.
There's a couple of written questions. Yeah.
No, Ninad, you cannot use this system for endoscopic third ventriculostomy. The reason is it's almost a 7 millimeter scope. Your foramen of Monroe is not meant for such a big scope. For cortical hematomas, or where you want to see the anatomy after you have completed a surgery. Say for me, I do a MIS CP angle. So once I have done it and I want to see nooks and corners, I can insert this scope. Okay. If you do not have the regular scope, but remember the regular neuroscopes are 4 millimeters, 2.7 millimeters. They are very small. So you cannot do a endoscopic third ventriculostomy with this. Okay, Kesar has asked, do you fix the endoscope with any holder? No, you don't require, because it is snugly fit. And also this is very important. Please, participants, understand that it is a joystick surgery. You know, as we do in the video games, it's a joystick. Especially anything which is free, try to use it to the maximum. So if you fix it, then it is very difficult. Transforaminal, in any case, it is fixed by the foraminal structures. So I don't use any. And in my next lecture, when I'll be talking about interlaminar approach, there also it's a joystick, absolutely joystick. What anesthetic agent you use and amount of local anesthesia for transforaminal blocks? Okay. So Brajesh, I use just simple Decadron. These days, the literature says that try and go for non-particulate steroids. So previously I used to use Depometrol, but now I use just about 1 to 1.5 ml of Decadron, and I use Sensorcaine or Ropivacaine. The Sensorcaine that you use should be preservative free, and that also about 1 ml of 0.25 or 0.5%. Okay, can you suggest which scope system is better and what is cost? Okay. Ideally, I should not be answering this in an open forum, but for me, I use a store system, and I use one more system which I've got from Indian vendor. So I have a combination, but my bulk of the work is done through the spine tip store system. I find it quite useful, versatile. And the main reason that I use stores is that the RF electrode is not a disposable one. I can reuse it, and I can attach it to my regular cautery. I have a RF cautery, so I can use it with that. Okay. But I'm pretty sure that with this one system, you can do 90 to 95% of your cases, especially with the Indian patients. So all interlaminars you can do with an 18 centimeter scope, all transforaminals except for very, very obese patients. So in extremely obese patients, I request storage people to give me a longer scope. That is maybe once in a year or so when I require that.
Yeah, Nanad asked, is that the same system we can use for ETV?
No, I've already answered. We can't use
Oh,
that.
I'm sorry. I should pay attention.
Okay, so I think I'll move on now. Okay. Okay, so here I'll share a video. This I have already posted on YouTube as well, so you can watch it again. Now this video, I'll try to, pause it and show it to you. So this is a left-sided approach that I'm taking. So she is a middle-aged lady who presented to me with sudden onset cauda equina. So severe weakness, both legs and feet, and retention of urine. So, the neurosurgeon who's with me, he didn't want us to go transforaminal. He said that she has cauda equina and not just radicular, and we should. But I was pretty sure that we could achieve a good result with transforaminal because the indications were right. Okay. So she had a huge disc at L4-5. So for me, acute L4-5, the box is ticked. Now, the second is migrated, caudally migrated, but not beyond the upper half of the pedicle. So that's fine. It has not gone cranially, so that's fine. Okay. So those boxes got ticked. Okay. On axial MRI, you see there's a huge disc fragment, and this has gone on to the opposite side as well. So I chose a left-sided approach in this patient. Okay, so again, as I've told, don't go beyond the middle pedicle line, medial pedicle line, insert your dilator, get your sheath in. Now, again, what I would suggest for youngsters is when you are putting in the sheath, again, you know the length of the dilator. Okay, so keep that and then keep on pushing it. At one point of time, you won't be able to push it any further. So then you have with this set, you will get a hammer and something to bang in. You just gradually bang it in till again you are near the medial pedicle line. Okay. And then you get your endoscope in. So here, this is left side is cranial. This is caudal, ventral, that means the disc area, and superiorly would be the superior articular facet. So here you can see this is the Storz RF electrode. This is what I'm using is not a disposable. It can be reused, and that is one nice thing that I like. So sort of cuts down the cost. Okay, now here, what I'm trying to do is, I'll play this video again, so don't worry about that. So here, I'm using a through cut to cut the annulus and part of PLL. And here, once I've confirmed, I'm pulling out the large disc fragments. So these are the large disc fragments I'm pulling out. Okay. So to make the anatomy clear here, this is the superior articular facet. Okay. The medial edge of the superior articular facet is the medial pedicular line. So after that, you will have the root and theca. This is the biggest piece that it could not come out through the scope, and so we had to remove it with the scope. It was such a large fragment, almost 5 centimeters long. So here you see, this is the same sheath. You can see the ball here. I've opened the cannula and my scope is not there. So I'm just grabbing it with a larger forceps. And this is the huge fragment that sort of came out. Okay, it's sort of inflamed. And after that, I'm again clearing other fragments. Now, at this point of time, now again for the anatomy, this is the traversing root here with PLL. This is epidural fat that you can see. The fragments have been removed from this part. On this side, you have the exiting root. On this side, you have the pedicle. And this steel thing is the sheath. So you are able to see the margins of it. So your endoscope is inside the sheath, but because there is an opening, you can see the structures in front and above. I'm sorry. Okay. Now, this is an important step that I want to show you. Now, as an interlaminar, I am rotating the sheath to sort of see only the disc. So in this opening, there is only disc. And I can, very easily, I don't need to think that I would be damaging any neural structure. And then again, I am derotating to see the neural structures. And here, so this is the epidural fat. This is part of the PLL still, which I would cut. So, okay, this is also very important. See, when you are cutting, you need to see the tip of exactly what you're cutting. So if I'm passing the instrument through the scope, I'll be blind. I can't see the tip. So what I'll do is I'll rotate the scope and see the tip and then cut. So please note this movement. Okay, please note this movement. So here I've rotated my scope, okay? And then I can see the tip. Can you see my rotation of the scope? Here again, I have rotated the scope. So I want to see the tip and I would rotate the scope in such a fashion that I can see the tip. Now the entire theca is seen. This I have gone beyond the opposite side. So, beyond the midline towards the right side. So I am clearing even the right side. If you remember on the MRI, we saw that there was a fragment going onto the right side. So here, this is the medial pedicular line on the right. So my RF has gone beyond that. Okay, so I'll play this part again. So this is the theca that you can see. This is the RF electrode and I have gone, so I have cleared everything from center to the opposite side. Now see the rotation for the pedicle. This is the pedicle here. Okay. You saw how I was rotating the sheath. So as I was rotating, I could see the part of the superior articular process and then part of the pedicle, inferior pedicle. So here I'm showing the inferior pedicle. I'm touching the inferior pedicle from inside. And this is the final decompression and you see how the dura is pulsating. And then I remove the sheath. This was the large fragment that we removed and a total of more than 5 ml. This was the post-op. The patient has started improving. These were the axial cuts. I've already shared this video with few. This is another lady with PLD, 40 years. She was, no, this is a male patient, I'm sorry, 40-year-old. He was operated 15 years back through the posterior approach. And this was the large fragment here, okay? So there was a large fragment, but again, I chose this because it is just beneath the, just a little lower. And I was confident that if I could catch hold of this part, I would be able to remove this. Also, if you see, there's a lot of scarring. So I didn't want to go through an interlaminar approach just because this is a little lower. Again, this I can skip. Yes, at this point of time, I used to use dye and methylene blue. If you want, you can use it. I've stopped using methylene blue or dye. So the blue thing that you see is the methylene blue. And this is the fat. Till the medial pedicular line, you can easily go. Here, you can see the opening. This is the RF. When you have such bleeding, you can sort of increase the irrigation. And this was the huge fragment that came out. So this is the large extruded fragment. I used to use methylene blue. This is the post-op. Now, this is the last few slides. And I've specifically brought this. There's a large disc. Patient had excruciating pain. Again, he had bilateral pain, left more than right. But I took a I took a left-sided approach. Though he had a lot of problems on the right side. And this is post-op 6 hours.
पहले से दर्द वर्द कुछ नहीं ना झंझनी वगैरह सब ठीक है मुड़ जाओ उसके रखो.
So this is after 6 hours. So there's a very happy patient, okay? But look here. This thing is all gone, but there's still a fragment here. I've counseled the patient that, look, I may, if you have recurrence or if you are not very comfortable, then I may require to remove this. But this is an incomplete job. So you must all be aware that this can happen. You should be very clear with your patient and sort of be ready to go in again through whichever procedure you want to. Finally, please don't use this to solve all your problems as far as disc is concerned. You know, we have a lot of technology with us. Newer technology is coming, but please do not try to misuse the technology. That's very important. Okay. So though I do a lot of endoscopic work, but I am in total love with the microscope. For me, if there are just two instruments in your operation theater that you should never compromise. One is a good microscope. The other is a good drill. So they are on top. So despite I doing a lot of endoscopic work, still microscope is my workhorse. Okay. So let me make that very clear. So all the participants and John, I'm extremely thankful for this opportunity. I hope I've been able to do justice to this, especially for those who have not started doing this approach. I'm pretty sure that the next part of this lecture would be on interlaminar approach, pure full endoscopic interlaminar approach, which we can discuss. I think John will tell us when he's scheduling the next lecture. Thank you. Thank you so much.
Very good. Thank you, Ashish. And we are in this for the long run. We know that it's going to take time for people to get used to this technology and interacting like they would at a conference. It'll come. It'll come. We just have to hang in there and keep at it. It's a valuable thing for a neurosurgical resident to brush up on this during these pandemic times. And some neurosurgeons too like to keep their hand in it, just to hear what's going on and review everything. So, so you've already talked about your topic next time, right?
Yeah, yeah.
Okay, very good. So we'll see you the same time next week, if that's okay?
Yeah, for me, it's okay. I'm fine.
Okay, very good. We'll send you the poster and banner as soon as it's ready. And thanks everyone for coming. Be patient. This is gonna work. Okay, we'll sign off.
John, can we